Kendria.
Welcome everyone to the Southern New Jersey Development Council Healthcare Committee's virtual event focusing on behavioral health and pandemic stress in the workplace. Thank you to our sponsor, the Cooper Medical School of Rowan University, and to our host for today, the New Jersey Psychological Association. Today's meeting is being recorded. There will be a follow-up email with a link to replay and download the presentation. The COVID pandemic has compounded the many challenges associated with stress and anxiety already existing in the workplace pre-COVID. The topic of today's session impacts all of us. Kara Burchell-Smith is the Executive Director of the New Jersey Psychological Association, New Jersey Psychological Association Foundation, and the NJP Political Action Committee. While she has a background in law, she has spent more than 10 years working in the nonprofit sector. Kira?
Thank you. Thank you so much for having me. I appreciate the opportunity to speak with you today and getting to know Jane a little bit more. We've had a lot of great meetings getting ready for today, and I look forward to the relationship after. Some of the blessings of the current year that we've had is virtual interaction. We were just talking about that in the small breakout room, that opportunities which might have been hard geographically are much easier now. So I really appreciate that, the multiple conversations that we've had and being able to talk to you. So I've created a couple slides. My intention is just to give you a little taste of what the New Jersey Psychological Association is all about. And I think somebody else is turning this. Yes, great. So the first slide I have is who we are. And we're a statewide association, basically for the promotion, protection, enhancement of the science of psychology and profession of psychology. We have approximately 1,700 members. Licensed psychologists, all the way down to those in training. We have some undergrad students who are interested in the profession of psychology, graduate students. Our biggest number of members are psychologists licensed 5+ years. So about 1,000 of our members have been licensed for that many years. And the other end is the students. We have about 125 students. So 1,700 members in our association. And then there's a total of approximately 3,600 licensed psychologists in the state. And our members are all over the state. In our small breakout room, I indicated that our central office is up in Livingston, New Jersey, but we have psychologists all throughout the state. And they work, they're in various career stages that I've mentioned, practice areas, from private practice, correction facilities, higher education institutions, different practice orientations. We have forensic psychologists, so therapy through testing and evaluations, many different opinions of how to approach the profession and life in general, and we welcome that. So that's our members, and I have a picture collage of some of our events that we've had. So those are predominantly our members, and sometimes family come to some of our events. So the next slide I have created is about what we do for our members. So the reason that individuals choose to join our association are professional development in general. And so in the ways that we can provide that is, I like to call it our 4 pillars, which are membership, advocacy, communication, and continuing education. So for advocacy, we strive to promote things that have to do with access to care. For example, telehealth, integrated care, serving, we're talking about serving students, higher education facilities. We just changed our licensure act to make it a little more efficient and fluid for people who are graduating and moving into the profession. We've talked about pain management and opioid. We provide continuing education. Psychologists now have mandatory continuing education up to 40 credits during their licensing period. 4 of those credits have to be on domestic violence. 1 of it has to be on opioid use and misuse. So every year we're providing robust continuing education programs for our psychologists. So not only on domestic violence and opioid addiction, but we have professional ethics, a wide range of addictive behaviors and compulsions. We have programs on the LGBTQ plus community. We have multicultural competency, harm to self and others. And as I mentioned, we're this upcoming year, we just had an ethics program that Dr. Susan McGrady, who you'll meet later, gave with our ethics committee. We had something, we're having something next week on immigration, and looking forward to moving through that. We also have communication. We talk to our members on a weekly basis. We have a journal on a quarterly basis. And we have professional development opportunities for our leadership development and to get involved with their peers. We focus on, like I mentioned, access to care, which could fall into the guild issue of promoting the profession, but they also overlap with social advocacy efforts. And we are involved both at, I said, the state, but we have a close alliance with the American Psychological Association. And every year, our delegates from our state association join all of the other state associations throughout the country, and the U.S. province, the Canadian provinces and U.S. territories. So that's this is the first year it's going to be virtual. It's held in March every year, and we talk about leadership development and all of the advocacy efforts happening at the state level and then at the federal level. The next slide I have is, I just wanted to mention that you know, one of the things that we wanted to introduce to this group and those members of this committee is that there's an opportunity to get in front of our members if so interested. We have a number of advertising and sponsorship packets for our continuing education programs, and like I said, we have publications. So if you're interested in getting to know psychologists, I'm happy to assist. The next slide I have created is talking about outreach. So we are in Northern Jersey, our central office, but we have, I mentioned APA was the national level, NJPA, the state level, and then we have county psychological associations, and they're listed there for you. I saw Dr. Hulan Nusan in the audience. He's met a lot of great people through the South Jersey Psychological Association, and Dr. Daniel Lee, who's our current president, has been associated with that group. So, you know, we consider this a grassroots of what's going on at the county level, state level, national level. We have been for a number of years associated with the Latino Mental Health Association and the New Jersey chapter of the Black Psychologists Association, and we're working together as a group, and that's at the bottom of the slide. Impact is the name of our group. We just met 2 nights ago, and we're planning on what we're doing for 2021. Much like everybody actually in the world and New Jersey and this group, we're focusing on resilience, right? That 2021 is all about resilience. And so this idea of kind of all gathering our belongings and ourselves and our minds and getting through 2021 after what we've experienced collectively in 2020. So I'm excited to work with that group again. We will do statements out to the public, and we are planning on a continuing education program for professionals. And you know, a lot of our programs, we invite legislators or representatives from the state or other organizations that are interested in mental health services. I think I might have one more slide, or that, yes. And then one other aspect that the NJPA is involved in is public outreach, and ways we do that is we have a statewide referral service for licensed psychologists, and Jane can help me share our information. Anybody can access that 24 hours a day, 7 days a week if you're looking for some help. We provide a quarterly public e-newsletter where our members write about hot topics. Our last one had to do with coping with COVID and the pandemic, and we put that out to anybody who's interested in reading it. We also send it to legislators so they can share it with their constituents. We are working on a mental health awareness campaign, and I mentioned we're going to focus on resiliency, and we're looking forward to podcasts, continuing education programs, statements, and getting information and resources out to the public about how to manage through this next year. We also have, as was mentioned when I was first introduced, we have a philanthropic arm of NJPA is our foundation, and we consider it the heart of NJPA, and we support psychologists in training in their education, research, and services to underserved populations. So we support when they're doing research papers, we give them money to help that. We help with community service groups that have students that are training and serving the public. And we also support psychologists in training who are looking to get educational opportunities and how to serve underserved populations. So we have a conference participation grant to get them out and to learn all about these important populations within New Jersey. So I'm happy to help in any way I can. Again, I'm so happy to be here, and I'm very excited that you're going to hear from Dr. Susan McGarty. She's been a real treat to work with within our association. And I look forward to getting to know all of you a little bit better.
Thank you, Kira. Dr. Jean-Pierre Issa is President and Chief Executive Officer of the Coriell Institute for Medical Research and is an expert in the study of epigenetics, how the turning on and off of genes affects our health, with a focus on better understanding epigenetic changes in aging and cancerous cells. Dr. Issa is also a leader of the Camden Opioid Research Initiative, a multi-organization research collaborative investigating the factors that contribute to opioid use disorder and overdose, and how genetic and non-genetic information can be used in the prevention or treatment of this disease. Dr. Issa?
Yes, good morning. Thank you very much for inviting me to speak to this committee. It's been a pleasure listening in already and getting to meet some of you. And before I go on, I think you need to allow me to share my screen if you want me to show my slides. So yes, good. So as I mentioned, I'm delighted to be here, and I hope you can see my slides now. Yes, good.
Yes.
So it's unfortunate again that we can't give you a tour of the Coriell Research Institute after this, but we'd love to do it at some point. Coriell has been in Camden for almost 70 years, and our founder, Dr. Coriell, was a leader in vaccine research and was very instrumental in getting the polio vaccine approved and in wide use in the United States. And we have actually been open through the COVID pandemic. We've done a little bit of work with COVID, but our work is essential for the National Institutes of Health. And so we've had to deal with how to make sure that our workplace remains safe and through COVID. And we've done a number of things such as institute testing for everyone on a bi-weekly basis now. And so anyone is interested, I'd be happy to share our experience with how to remain open through the pandemic here. But today I'm going to tell you about an exciting initiative, which is the Camden Opioid Research Initiative, which was started prior to me joining Coriell, but that I currently help steer. And so let me just start here by just reminding you that before COVID, opioid was actually an epidemic in the US and continues to be an epidemic in the US. It started in part in the late 20th century with extreme marketing of OxyContin and like drugs in the US that has led to a dramatic increase in prescription drugs, in particular prescription opioids. And the misuse of these drugs and eventually of other drugs has led to an epidemic of opioid-related death, and the CDC declared it an epidemic in 2011. The NIH estimates that about a quarter of people who are prescribed opioids for chronic pain misuse them, and a number of them will go on to develop opioid use disorder. And interestingly, if you look on the other side of the coin and ask, how do people get addicted to heroin, which is one of the biggest killers we have currently, about 80% of people addicted to heroin started somehow with prescription opioids. And so there is a dramatic epidemic that has continued in the US through the opioid crisis. So you might ask, well, what happened to it in COVID-19? That maybe there's been less access, or maybe there's been a diminution of the crisis, and unfortunately not. The magnitude of the crisis continues to be high. about 10 million people in the US abuse opioids or misuse opioids every year. 47,000 died of opioid overdose pretty much every year for the past 10 years. The cost to the US economy is estimated at about $200 billion per year. So it continues to be a big problem in the US. And in this one study that looked at 73 million patients at many, many US hospitals, they found that patients who had opioid use disorder were significantly overrepresented among those with COVID-19. So among their COVID-19 patients, for example, 15% of the opioid patients had COVID compared to 10% of the control group. So patients who have an opioid use disorder turned out to be at higher risk for developing COVID-19 and for developing complications because they tend to be immunosuppressed and have comorbidities as well. In fact, patients with a recent diagnosis of opioid use disorder were about 10 times more likely to develop COVID-19 than the rest of the population here. And the higher risk of contracting and suffering of COVID was especially true for African Americans with opioid use disorder. And this is, of course, a big problem in New Jersey, including in southern New Jersey. So to give you an estimate of how it is, the state actually maintains an excellent website where they keep records of what is going on in terms of opioid use and misuse. And from January to November 2020, there were about 3 million opioid prescriptions, 13,000 naloxone administration to reverse overdose, and unfortunately about 2,800 overdose deaths in the state of New Jersey. And if you wonder how that compares to previous years, this is the graph. The blue line represents the number of drug-related deaths in the state. And you can see that there was a marked increase at and around 2014, which started leveling off at around 2018. But unfortunately, 2020 does not look any better than 2019 or 2018. And so the epidemic has continued through COVID-19 and continues to rage today. Interestingly, the number of prescriptions for opioids have decreased very regularly over the past years, but this has not yet translated into a decrease in drug-related death. It may be that it takes several years of a lag to see the effect of the reduction in prescriptions, or it could be that there is more than one factor at play here, and that this plateau might continue for several years without some sort of more active intervention, and that is active beyond reducing opioid prescriptions in the states here. The Camden Opioid Research Initiative is a multi-institution initiative that started, as I mentioned, around 3 years ago. It is led by investigators at the Coriell Institute for Medical Research in very close collaboration with investigators at the Cooper University Hospital or the health system, as well as the Cooper Medical School of Rowan University here. And in the first few years, we've also collaborated with the medical examiner of Gloucester County in New Jersey here. And the goals of the initiative is to collect data, to follow patients, and to collect genetic material, essentially to ask questions about the genetic and environmental factors that impact opioid use disorder risk and treatment. And there are 3 components to the study. There's a component that is focused on chronic pain patients who are exposed to opioids, and we are trying to understand why some of them go on to develop opioid use disorder while others do not. It also focuses in a separate group on patients who are already addicted to opioids, and we are looking at the success of treatment for opioid addiction here and trying to see whether there are genetic or epigenetic factors that predict that success. And finally, we are collecting in a biobank, we're collecting biological samples from patients who died as a result of opioid use disorder or a drug-related death in general, again, to try to understand why this is happening here. What we are collecting is blood toxicology data, clinical information. We are doing a number of genetic and epigenetic studies on both blood and saliva, and we've been able to collect some brain tissues from patients who died as a result of COVID, as a result of the opioid overdose, and we are looking at the brain-specific changes that are associated with opioid use here. This is what is being collected in the study, and we've now enrolled about 300 patients overall in the study, and the clinical part of the study is led by Cooper University Health System physicians, and we're looking at a number of clinical surveys, questionnaires, and pain assessments here. We are also collecting, as I mentioned, genomic and epigenomic data from patients who died, from patients who are currently on the pain component of the study or on the addiction component of the study. And we're hoping to start reporting on these results over the next year. This was a control group of patients seen at the Cornell University. Now, I do need to show you a little bit of the data because I think we are finding some things that are interesting and could be potentially relevant to Southern New Jersey and to the workplace. So this is an analysis of the blood toxicology data from patients who died as a result of COVID. Again, keep saying that, who died as a result of the opioid epidemic here. Now, this slide was strongly objected to by Courtney Dirks, who's our Chief of Public Relations, because she says no one understands it. And I told her that as a scientist, I'm contractually obligated to show you things that you don't understand. You know, actually, this is a very simple slide. It's really not that complicated. Each of these columns is a different patient who died of a drug overdose, and each of the rows is a drug that we detected in the blood of these patients here. And what you see is this pink row here that is present in pretty much every single person in the study is fentanyl. In other words, fentanyl was responsible for more than 95% of the drugs present in the patients who died as a result of this opioid epidemic. And it is really fentanyl that essentially is a cornerstone of the causes of death of these patients. But almost no one had only fentanyl in their system. Almost all the people who died of this drug overdose died as a result of a combination of fentanyl and something else. These patients all had cocaine and derivatives in the blood. These patients all had heroin and derivatives in the blood. These patients had amphetamines and methamphetamines and others. These patients had cannabinoids and so on. And in these patients, we only see fentanyl, although, you know, we could have missed other drugs as well in this system here. So the biggest message is that the drug that we have to worry the most about is fentanyl, and that what we have to worry the most about is patients who are not the chronic pain patients who are on single drug treatment for pain, but the people who somehow are addicted to multiple drugs, including cocaine and heroin, cannabinoids, and potentially other drugs as well. And one of the findings of the study was looking at fentanyl levels, and we can look at how quickly fentanyl is metabolized in the blood to norfentanyl. And this is an interesting finding in that people who had cocaine derivatives in the system had relatively low levels of norfentanyl and fentanyl, which means that when they received fentanyl, it actually took a long time before they died as a result of drug abuse. And that's because cocaine initially counteracts the effect of fentanyl. But as cocaine wears off from the system, and cocaine wears off a lot faster than fentanyl, fentanyl kicks in and these people die. These patients have very high levels of fentanyl in the blood, and they die much more rapidly in the absence of cocaine because cocaine is a stimulant and it counteracts the effect on the respiratory system. So these are the kind of data that we are generating now, and this is the data that potentially could be useful for prevention and looking at the immediate causes of death in these patients here. But obviously, we still don't understand a lot of things in patients who are addicted to opioids. So in conclusion, Opioid-related death continue to be an epidemic in New Jersey, and this is despite a reduction in the number of opioid prescriptions, and we need to understand why and how to treat that. I showed you our data on the toxicology on that fentanyl and combinations with other drugs is a major contributor to drug-related death in southern New Jersey here. And one of the big question marks continues to be, why is it that some people get opioids and become addicted to them, and many people get opioids and never get addicted to them? And this is a fundamental question in medical practice right now, because opioids are good drugs for patients with pain. And we do not want to, a world that does not have any opioid for chronic pain or for acute pain, because they are actually wonderful drugs for patients who need them. I happen to be an oncologist, and in my field, there's a lot of people who need a very good drug treatment. However, a lot of people suffer as a result of these drugs. And if we can simply understand and prevent the consequences of opioid use, I think we would have made great advances in the field, and that is really the goal of the CORI project. So I want to thank everyone involved in the CORI project for their work on here, and I want to thank you all for your attention. I'm happy to answer questions if there are any at this point.
Thank you, Dr. Issa. That was a fabulous report, incredibly important research that you are doing. I'd like to introduce Dr. Susan McGroarty, who is the Director of Professional Affairs for the New Jersey Psychological Association and Director of Behavioral Medicine at Inspira Medical Center Family Medicine Residency. She is an Associate Adjunct Professor at Rowan School of Medicine and an Adjunct Professor in the PsyD program in Clinical Psychology at Chestnut Hill College. She's written articles, book chapters, and given numerous presentations at regional and national level on very many topics. She has served as co-chair, chair, and invited member for regional and national psychological organizations. Dr. McGroarty.
Thank you so much. I want to just, I need to be able to share my slides. Perfect.
Yeah, Ben, we could have taken care of that. Dr. McGroarty, you just need to tell Ben just to move your slide forward.
Okay. All right. So from now on, he'll move my slide forward?
Yes, yeah, just
okay.
Yep.
Are they showing?
Yes, they are.
Oh, okay. Because I can't, oh, there we go. Okay. So I just wanted to thank Dr. Issa, merci Dr. Issa, for his wonderful presentation on the opioid crisis, which can significantly affect the workplace. And today I'm going to talk to you about what's called the boomerang mental health crisis as a result of COVID-19. And I want to start out by saying that, here we are, we humans are social animals, okay? There's so much research to show that when humans get together in packs or tribes or groups, that our anxiety and our emotions downregulate. For most of us, we need to be around some people some of the time. So it's no surprise that when you have the combination, like we've had in the past year, of tremendous uncertainty, fear of death, and political polarization and social unrest, that we have a mental health crisis. And in fact, the mental health, can you advance the slide? The mental health crisis is so severe that there's been talk of changing the norms for the PQH9. If you've ever been to your family doctor, you've probably taken a PQH9. It's usually sitting on the exam table when you go in. It's used routinely in primary care to assess patients' depression. And we're finding nationally that people are expressing so many symptoms that the norm, that what usually was the cutoff for depression, either has to change, or we have to start to really identify more people that, you know, the depression and anxiety are the norm. A recent study I read in preparing for this talk said that 40% of Americans would qualify for a clinically significant anxiety disorder at this time. Okay, please advance. So I wanted to talk to you about understanding anxiety. So with all the stresses we're under, it's a threat to our survival. And so what that does is it, and this is very simplistic, but it turns on a switch in the brain where our bodies and our minds are in constant vigilance for threats. Okay, and some say that switch is much easier to turn on than it is to turn off. And the group of people that figure out how to turn that switch off, that might be like Nobel Prize winning science. But for right now, we just know that once humans turn on their like anxiety and arousal, it's very hard for them to turn it off. Even after the threat is gone, some of that arousal and anxiety will still continue. Okay, so, okay, please advance. So what does that mean for you as an employer, as a business owner? So when humans are that anxious or aroused, we see a neutral stimuli as a threat. Okay, so say I'm in Wawa. Don't we all love Wawa? Okay, and usually at Wawa, people hold the door for each other. So let's say I'm going out of Wawa with my delicious coffee and somebody bangs the door at me. If I'm really worked up with this arousal and anxiety, I'm going to see that as like, that is so rude, instead of just seeing like, whatever. Okay. And I think that's important to understand that when we do go back to on-site work, people, even though the pandemic may fade, it's going to take longer for humans to decrease their arousal even after the pandemic is over. So in the workplace, it might be common, you know, if somebody leaves you out of a meeting or says something, you know, offensive, that people's reaction might be a little bit more aggressive or anxious than before the pandemic. Okay, please advance. Which leads us to the challenges of returning to in-person work. So one thing we look at when we look at this whole arousal and anxiety is, what are the hassles? You know, because sometimes we don't need major things to make us irritable and cranky. It's just the daily hassles. So for example, commuting. I regularly commute to Inspira, and it's wonderful because I can get around that 42 curve in a heartbeat. That never used to happen, so I don't have that hassle. But when we all return to work, we will have commuting hassles. Childcare hassles are going to be major as people, you know, transition. You know, at some point, all the schools are going to be open, but you know, children have slower than adults for the most part to like a childcare transition. So there's going to be stresses related to that. And then something as simple as what to wear to work. Okay. I know I've been wearing my exercise pants way too much. And the days I go into the office, I really have to think like what fits right now, because many people have gained weight and might be self-conscious of their appearance. And, you know, while this isn't a major stressor, it just adds to like the hassle. And when you combine that to people already being more aroused, you know, hassles are going to increase that. Then we all have rusty social skills. I mean, certainly Zoom and Skype and FaceTime help, but social skills are learned behaviors. And for some of this, social skills come very naturally. For some of this, social skills are something we have to work for. So when we all get together at work, on top of these other challenges, for many people, it's going to be, you know, getting used to being around people, which kind of leads into fears. So during the COVID-19 pandemic, especially with this latest round of highly contagious COVID, it's a little scary for people to be too close to you. Keep your germs to yourself. I don't want COVID. We might have a fear of being around people. People might have a fear of being scrutinized. One study I read about at-home work is that people feel less scrutinized at home, like they don't feel like their boss is maybe like looking at them, quite the same way as, the product of the work is more important than the micromanagement. So that might be a transition for some people. Uncertainty is going to continue. COVID is here to stay. COVID has, and the other factors have left us, with significant issues about trusting one another. And then, as I mentioned, social proximity. And then another thing to consider is that 40% of Americans can qualify for a clinically significant anxiety disorder. So when people are coming to work, they're bringing their mental health problems with them, which really speaks to the importance of actively addressing and identifying mental health problems. I mean, anxiety and depression are very, very treatable, but they have to be identified. And of course, the person has to change. And then finally, I do have to speak to, currently there's an escalation of political polarization, which has led to conflict. And I've already talked to some people that are seeing more bias and discrimination incidents in the workplace related to the political conflict. So, while being at work together is going to maybe help our attachment issues and is more natural to us as humans, certainly it's going to bring some changes. Next slide, please. So what are the possible sequelae? How's this going to affect your bottom line? Well, certainly mental health issues are associated with absenteeism. They're associated with absenteeism directly because people feel miserable. And it's well known that mental health conditions like depression and anxiety give rise or comorbid with many medical conditions. So taking care of your mental health is an important way to take care of your physical health. There are also probably going to be many more stress leaves. Already in my clinical work, I see many, many people coming to our team for the first time requesting a stress leave. I just can't handle work right now. So that's going to put a burden not just on the employer, but on the state disability funds. There's going to be more employee turnover. When people are depressed, nothing's right. So they could blame their job when it's really them. Clearly decreased productivity and increased and possibly escalation of conflicts in the workplace because people are more aroused. It's like kindling. I'm already stressed out enough, and then you say this, okay, let's have a conflict about that. And then also certainly more increases in bias and discrimination complaints. Okay, please change. Okay, can we change the slide? Thanks. Okay, so what are we going to do? We can't call Ghostbusters. So let's use our resources to figure out how to manage the transition. And in mental health, one of my favorite things is the best thing many people can do for their mental health is manage your expectations. Okay, and having realistic expectations of what humans are capable of, I think, really helps us to lean into reality of what people are capable of, and then not get disappointed and frustrated when people can't measure up to unrealistic expectations. So, some people say, we need to reorient to the workplace with flexible schedules, not like a dramatic, okay, you're working 5 days at home and now you have to be 5 days in the office. And, create like a culture of cooperation, we humans, we're all in this pandemic together. There's not a person on this planet that isn't in the COVID pandemic, either directly or indirectly. So how do we move from a culture of conflict to a culture of, like, a team of cooperation? And so some people are saying, like, the way to do that is to have like an individualized department approach. So, usually managers know their team, and, so being able to tap into your managers and empower them to maybe do an assessment of what their team needs as a team. And then if there's any individuals on the team that might be particularly at risk, to maybe think about how you can use your EAP or HR resources to address like the needs of that team or the needs of that individual. It might also be a good time to, re-educate managers and leaders about, hate and bias crimes or hate and bias in the workplace, and discrimination, different forms of discrimination, so that we can all bring our best self, our most professional self, our most compassionate and loving self to the workplace. I know that Inspira is doing town halls on a regular basis, which is terrific because, there's so much anxiety, and anxiety gives rise to lack of trust. And then you get like all the gossip and rumors, and town halls are a wonderful way to dispel those rumors, and, be in front of providing, excellent and accurate information for team members. Okay, I think next slide, please. Okay, so all of us, can benefit from mental health. I'm someone that believes that mental health doesn't have to be therapy. I think therapy is amazing, changed my life, but we can build therapy, or we can build mental health things into our workplace, into our everyday lives. So, look at your stress management program. Some companies are starting to provide stress breaks. So just like people can have tobacco use breaks, maybe giving your employees like a 15-minute stress break so that they can go do some yoga poses, or throw a load of wash in, or kiss the baby, or, maybe do some mindfulness, and making mindfulness apps and supporting mindfulness. Mindfulness is important. You probably know, everybody's heard of it, because what mindfulness does, anxiety makes our brain scattered. Okay. And mindfulness teaches our brain to focus. Okay, so it's a natural way to decrease anxiety and arousal, and it's very easily accessible. Like, we used to think of mindfulness, I used to think of it as like I had to go on a retreat for a month and sit in cross-legged position and say, but apps like Headspace have made mindfulness so approachable. For example, if I'm feeling really stressed out, and you can imagine from my 2 jobs, that happens every once in a while, I do a 1-minute Headspace mindfulness app. I just, and it's 1 minute. Decreases my arousal, my feelings of overwhelmness, helps me focus, and I can get back to work and being productive. And then also, anything your company can do to reinforce healthy behaviors, such as exercise and healthy eating. I know, again, Inspira is doing, like a healthy lifestyle program. I've worked for companies before where like they had an exercise challenge, and you got like little awards for exercising. Those things work. Like the PREMAC principle is one of the most powerful principles in psychology. And it says, behaviors that are reinforced will continue. So if you want to have a healthy, vital, productive, and diverse community for your workplace, reinforce healthy behaviors. And I think that's my last slide. Yeah, it is. Okay, thank you for your time.
Thank you, Dr. McGroarty, and thank you, Dr. Issa. Dr. Issa, I will agree with Courtney on that one slide, but you made it very easy, so you were both correct. How's that? I got to play it even as a facilitator here, but really thank you both for making it easy. Dr. McGroarty, you're going to stay with us for this panel, right? And so actually, before we get in the panel, I just want to take a quick second. I know we're running behind, and encourage you to stay with the program. We'll probably be 15 minutes late. I don't know a topic right now that is as important to really embrace and understand as this here, because we all want to get back to the office, but I fear that we don't know exactly what we'll be getting into when we finally do. But I want to recognize our chairman, Glenn Davila from Performance Marketing. Glenn, thank you for making the time and for being on here today. And I wish you well in your time as our chairman. So thank you. Also joining our roundtable, obviously, will be Dr. McGroarty, Marjorie Obad, who is partner and chair of the Labor and Employment Group at Dilworth Paxson. Marjorie dedicates her practice to providing counsel to corporate clients and nonprofit organizations in labor, employment, and regulatory matters. She handles jury trials in general litigation, including the employment area, wage and hour audits and reviews, Title VII cases, and various other disputes. That all says she's very, very smart and knows the law extremely well, as you'll find out here in a second. We're also joined by Mary Custer. She's an advanced practice nurse certified in adult medicine and addiction services at Maryville. And she is our, and I say our because I have the privilege of serving on that board, our director of nurses. We're just surrounded by smart people here today that know much more than we do. So I've been taking copious notes. I'm going to start with probably a few questions, and then we're going to shift it out to you for questions. So we're going to first start with Dr. McGroarty. Can you give us a 30,000-foot view of what we can expect when we get back into the workplace as pertains to, obviously, the employees coming back and readjusting and what have you?
Yeah, so I would say a combination of excitement, relief, and apprehension, and confusion about what life is like. Humans don't like change in general. While we might look forward to a change, we're also going to feel stressed by a change. So for example, if those of you who have ever gotten married, it's exciting, but it's stressful, okay? Because we humans, change is hard for most of us. So that's what I would say.
Okay, all right. Marjorie, are there policies? This is really, I thought of Marjorie. You're probably going to get the majority of these questions here, because one of the battles is engaging with employees, even and especially when you know or you believe they need some assistance or may need some assistance, and managing that. When do I talk to them? How do I talk to them? All that good stuff. So are there policies or best practices you can recommend to employers and to employees with regard to returning to work post-pandemic and bringing with them the anxiety, the arousal, and all of that newness, as strange as it is?
Well, I want to kind of focus on two different areas. One, I want to piggyback on everything that Susan is saying, that I think it is really an opportunity in a way to deal with the issues that relate to the diversity issues that have been coming up as people are returning. Because one of the things that I've noticed in dealing with people as employment lawyers, everybody's impacted, and yet people don't recognize the impacts on other individuals. So I do think that having a intake process where at least you're communicating with people about the different ways everyone's being affected, and making sure that you do address that to everybody, that everybody's being affected, and let's make sure that we're trying to be understanding in the way that people are returning to work, sort of addresses these other issues that are really in front of everybody to deal with also, on how we're dealing with diversity in a larger scale, which is really incumbent on organizations to look at. But I think when we're looking at this, you're asking me more about the legal issues, and I have been dealing a lot with South Jersey organizations, and I have to say I've had a lot of the issues, even with opioids being a problem. And so I think that the one thing I want to say legally is, even with respect to individuals returning to work, what are your policies? Do you have drug and alcohol policies that are in place? And certainly if you have Department of Transportation requirements, and I don't know how everyone's aware of this, but in 2017, 4 of the added tests related specifically to opioids. And, if you have policies in place, do those policies actually require that you do some testing if there are individuals who've been out of work who are returning to work? All policies don't have that, but there are policies that do. So for someone who hasn't been at work for 4 months and is returning, do you have an obligation to be testing just based on the fact that they haven't been to work and are returning? So I think you need to look at your policies. The biggest issue that comes up is really most policies don't have a lot of those requirements, even if they do have federal obligations or federal governmental, if you're a governmental entity, if you have federal obligations to do drug testing. Most of the policies really deal with reasonable suspicion. And I think on a call we had earlier prior to this session, there was some discussion about, what are you really looking at for reasonable suspicion? Is it the absenteeism that we talked about and the being tired? Some of the things that are the stressors may also be indications of drug use. And, how are you making sure that you're looking at those issues and being aware of that there could be, drug issues that are at play that you want to address. And then the issue is, how do you raise those issues? So the basic issue there is to make sure that what you're looking at is whether or not someone's performing the essential functions of their job. So if somebody has absenteeism issues, that's going to come into play as to the essential functions of their job if they're not showing up for work. And then you get to the issue of what the dialogue is to be able to address somebody as to whether or not you need to do drug testing because you have a reasonable suspicion. So those are the things that I wanted to make sure that everybody's clear on in terms of how those conversations take place in the umbrella of trying to be inviting people to come back to work and dealing with these stressors. So it is a complicated area, but it's also, obviously very significant if you have a workplace where you have people using machinery or making sure that you're addressing the OSHA requirements that you have a safe workplace. And so, drugs can be a problem for the workplace in terms of creating dangers for other individuals. The instances that I have encountered just during this pandemic have related to individuals where there has been discussion, even you're hearing about the drug use from other employees, so that the reasonable suspicion has been based on someone actually talking about the drug use. And so that's an easy one. You can easily go to somebody that you've heard this and that they're going to need to get tested. With respect to even opioids, you get to the issue of whether they're legal or illegal. So if someone is on a prescription for something, that's illegal use of drugs. That obviously then they are protected because they have a disability. They're under the ADA that have the ability to use those drugs based on the fact that they are being prescribed the drugs. On the other hand, is that something that they can actually work? Can they do their job? If their job is using heavy machinery, are they able to work, or are you going to have to put them on leave? And, if you put them on leave, is that going to be paid leave or unpaid leave? So those are the issues that come up. If it's not legal, then you get to the issue of what's the stance you're taking on that. If you're taking a kinder approach and saying, we're going to, provide you, with some sort of program to let you try to address that issue, you do not have to do that if it's illegal drugs. When it comes to alcohol, it's different than drugs in the terms of if someone has an alcohol problem, and we may have people returning to work who have problems with alcohol. If they're in a program, then they are protected. So they'd have to be in a program to address their alcohol use. So I think that, the big issue is to look at first, what are your policies? What kind of testing can you do? And then to look at, ADA issues. Is it a disability issue? What is your policy as an organization in terms of, I think what Susan's talking about, recognizing that there are stressors, what is your approach to dealing with employees and making sure that you're consistent in the way that you are dealing with them, so that you're not treating people who are in one race different than another. And right. I will say that the biggest one that comes up, and I think that often does, is that race is particularly an issue that historically in cases, there's been findings that employers have treated people differently based on race. I
don't think there's any question there, sadly, at all. You're absolutely right on that. There's so much you're talking about, and it's, I want to circle back to some of that, but Mary, I want to ask you a question. So, for those of us who have employees dealing with absenteeism or presenteeism or loss of productivity, and the myriad of other things that are coming from this anxiety-ridden culture that we are all operating in, for those who have not experienced it, dealing with somebody with substance use disorder, because we're not just talking opioids, we're talking all substances, including alcohol, which is something we need to talk more about, not this morning, but in general as a culture. Can you give us real life examples of what employers should be looking for with regard to whether somebody is potentially using or abusing medications, illicit drugs, or alcohol?
Well, I think, the absenteeism and the decrease in production are all late signs, which is unfortunate, because by the time it comes to that, they're already, if they're drinking on the weekends or doing drugs on the weekends or whatever, by Monday, they can't make it in. And, that's pretty much very late. So if you want to catch it earlier, it's those signs of anxiety or being withdrawn or not being their usual self. Being home for a long period of time gave people a lot of options to self-medicate, to take care of their own depression with either a red or a white bottle of wine, and to take care of either the big question too that was brought up as well is whether it's, illegal drugs or illegal prescription. Where do we define whether somebody is actually impaired or not? What's the definition of that, and who gets to make that? So, and where are these people, as far as being protected, whether it is a disability or not? If you're taking Xanax for anxiety, who's to say if your head is hitting the table that perhaps maybe you're a little over sedated, and who gets to make that decision? You'll notice it's oftentimes a little bit too late too. By the time you see somebody with their hands are shaking uncontrollably in the morning and their coffee cup is just banging up and down, and it's kind of a little bit late by that time that starts to happen, or by the time we get to see that. However, it's how miraculous it is that after lunch that they're calm and cool. So you got to think, did we take care of those tremors at lunch? It's very difficult. And then a lot of people are afraid to ask the question. It's like, hey, it depends on who has the rapport with that person too, because you want to be able to say that, from my standpoint, obviously I want to help treat the people that are addicted. And then what Dr. Isra said is oh my gosh, is it genetic? Why do you become the alcoholic and this one doesn't become the alcoholic? That's the $1 million question. And maybe the end of my job if we figure it out. But that being said, we just want to just keep our eyes open for the subtle signs.
And so along those lines, and I'll pass this question back to Marjorie, is as an employer, when you see something that concerns you, and I may just be speaking for myself, however, this is a discussion that comes up with a whole lot of our insured clients, is the fear of, okay, when should I speak? How hard should I be? What if they say they're fine? Where does that line end up in the sand between an employer being too in the business of an employee? And we could always use the example of a heavy equipment operator driving the bulldozer into the side of a building. There's no questions there. But where is that line? And how does an employer know when or what to say? And Marjorie, is there anything that you suggest that employers do to take a precautionary step in that approach to an employee? Hopefully they're doing it for human reasons, but we also run businesses, so you got to keep the lights on. So you got to stay productive and generate revenue. So what would you suggest employers do, Marjorie, in those instances? I mean, that's a precarious egg walking thing, right?
Well, I think when you're talking about an individual and performance with an individual, so I think a lot of the things even that Mary's talking about do end up impacting performance. So maybe it's not quite to the absenteeism, but they're not focused as well. So I think one, you have to have somebody who's noticing a change. And I think that the most important part is to say, we're noticing that your performance isn't at the same level. And we're concerned, about that. We need to see you getting back on track. And the advice is to not say, we think that there's a problem. You have a you know, what else is going on, but to tie it to the performance issues. I think that, you know, what you want to make sure you're doing, because I think that what we're talking about is this is something that's going to be happening with more than one employee coming back into the workplace. So I think that Susan's advice about making sure that we're having, you know, whether it's the director or supervisors having conversations with the group is helpful to make sure that these issues are being addressed, not just on an individual basis. So the person who's maybe going to end up being talked to on an individual basis already heard that, you know, we're concerned to make sure that everybody's going to have stressors. We want to make sure we're being supportive of this. And, you know, I think that you have to be attuned to it so that someone may come back and, you know, I think a lot of people aren't going to want to admit that they have these issues. They may not even admit it to themselves. So they may not, in the first instance, talk about what the issue is. But if you keep coming back, and I think that it really is, I think, incumbent upon employers to make sure that they're talking to their supervisors about these issues and to make sure that the supervisors are talking to the staff that they report to. But the main issue, I guess, back to that is, you know, so you want to set the groundwork right, but when it comes to the confrontation with the employee about the issue is not to, you know, if you do, like I said, in the instances I've had, there's actually been reporting from other staff that there is a concern. So it could be, you know, we're hearing that there's a concern, you know, and it's affecting your performance, but you don't want to confront them with, we think that you're drinking, or we think that that's getting too close to the disability issue of the employer raising it. And I think that's what I would counsel against, is coming up with what you think is going on. If you don't know what's going on, you want to make sure that you're eliciting the information.
Okay.
That's my advice.
Interesting. One interesting aspect of all this that some are embracing and some are having a hard time embracing is, and it's really a beautiful thing that's come from all of this, and I say all of this, the pandemic of COVID and the epidemic of substance use disorder, is the human approach that some employers are going to have to take. And it's really a beautiful thing, because now you're dealing with individuals and not just, for lack of a better phrase, production tools. And so even with that, Dr. McGroarty, I just want to ask this last question before I open up to the audience. As an employer, the contemplation of approaching somebody, depending on who that is, and we all know that hard employees do exist. They don't respond well to even the most loving of challenges. But is the additional anxiety on the business owners? I mean, we could talk any size business, but of that interaction. And so, Dr. McGroarty, do you have any suggestions on business owners working through that, or supervisors, or whatever phrase you want to use, somebody who has to approach somebody else?
So I guess to piggyback off Marjorie, there are certain ways to discuss this with an employee that are more legally advisable than others. And I think your point is great, Frank, that, you know, most people get anxious to have these confrontations anyhow. And then when you have all these other things going on, that anxiety is just increased. So I think it would be important to teach your whoever's doing that confrontation, like, to just take a deep breath, take a mindful minute to settle yourself before you go into that. So that, because if your anxiety is too high, your cortex, your brain, your thinking brain can't work. So it's really important before you go into a challenging meeting to, like, just take a moment to, like, breathe and, you know, do some self-talk, maybe do a 1-minute mindfulness, so that you're calm and you can be in your wise mind versus your anxious mind.
Interesting. You just cleared up a question I had. So I do have a wise mind and a different, so that answers some questions for me.
We all got it.
Thank you. Well, this time I'm going to open it up to questions. You can either put your questions in the chat, you can raise your hand. Actually, those two ways work best. And I just want to remind you, other than some of the professionals that are on here, and even with that, this is a learned thing. And we as a business culture will learn this response and approach to these issues in the workforce together. There are no dumb questions, and chances are, if you have a question you think is only you're probably wrong, and there's other people hoping that you're going to ask that question. So no questions off the table. And so I open it up to the floor now for any questions.
Well, I'll just, it's not a question, it's a comment. I just suspect that when employers are returning to the workplace, that it'd be difficult to determine that assessment as to where their performance has dropped off. Has, you know, is the comparison between today and how we were performing pre-pandemic, or are we assessing performance as, you know, the little creep that's occurred over the almost year now, and now the performance expectations are that much lower as a result of the past year and the compounding anxiety and unknown?
Wow, that's a great question. Any of the panelists, please feel free to jump in on that one.
I'll jump in. I think that regardless of whether someone has an addiction issue or a drug issue, or if it's just anxiety, I think that you're going to have issues coming back to work, as everybody having at least the anxiety issues, even if they don't have the other piece of it. So I think that that's where you really want to make sure that you're talking to your supervisors as to being aware of these other types of issues. Are they being able to focus? You know, and if they aren't, I mean, I think even though you're having the conversation isn't saying to someone, are you using drugs? It's, you know, what can we do to help? You're not focusing the same way. So I think some of it's just going to lead towards what Susan was talking about before, of what other programs can we put in place? What other wellness things can we do? And some of it's going to be addressed that way. In fact, you may end up solving what could be an alcohol problem by providing some resources that are being addressed based on just anxiety without identifying it, that is a resource that person needed. So I think that, you know, I think that you're right. I think that a lot of people are going to have anxiety. I think that, you know, Susan's point, which she raised, of even people getting into spats, things like that, you know, are anxiety, but they're also potentially drug issues, you know. So I think that a lot of it initially is being approached as, you know, how can we support you? But then as you go forward. So I don't think that, I doubt that it, other than, like I said, the instances where I heard somebody, you know, themselves had talked about going and getting certain kinds of drugs and you hear about it. I think a lot of it's going to be approached initially as, you know, what can we do to support you? And if it goes on in a way that you're supporting and it's not working, and you may get to the point where you're recognizing that it is a drug issue.
We just had, well, first of all, before I get to the one in the chat, Courtney, was your hand up before Jane spoke? No, okay. So a question just came in is, what is the employer's responsibility when the employee's performance has clearly, which I think is, their statement really is that it's unquestionable that it has declined, but the employee denies an issue. So Marjorie, I'm sorry, this probably ends up back in your lap again.
I think that that's sort of focusing on the performance is helpful, because if they have a performance problem and they're not coming forward and telling you that they have a reason that they may need an accommodation or, you know, another way to address it, they have a performance issue, and you'll be taking them on the road of saying that the performance issue could end up resulting in discipline up to and including termination. So I think if you have an employee that has a performance issue that's declining, you want to make sure you're documenting it. You want to make sure that you're open in the conversation for them to raise these issues, especially if it is something that you can support them with, if you're an organization that wants to support them. I can tell you, I represent employers who aren't going to worry as much about the issues that they don't need to deal with. If it's an illegal drug, they would just fire the person. So, you know, you have to be cognizant of the employer you're dealing with. But if a person has performance issues, it's declining, and they don't raise the issue, they probably will end up getting terminated based on their performance problems. It's their opportunity, and it's your conversation that's going to elicit from them maybe a dialogue that would have you help and support them so that they could return as a good employee after having addressed the problem in a way that's mutually helpful to both of you, to the employer and to the employee.
Gotcha. I just want to recognize this program could really be far longer and more in depth. I appreciate your patience. I'm going to take one more question before we close out. Is there any more questions anybody has? And again, none are off the table. No other questions? Okay, Jane, I'm going to turn it over to you.
Well, with that, I just want to, thank you all for joining us this morning for this conversation. It's the first meeting of the Healthcare Committee this year. There'll be others that take place. We've got two things coming up. The Transportation Aviation Committee is meeting next Friday with Assemblyman Moen as their speaker. And then the Government Affairs Committee is meeting on February 24th with Assemblyman John Bosicelli. Lots of things going through the legislature these past several months. So those would be two interesting invitations for you to take part in. I want to thank our speakers for their time this morning, and also to thank our presenting sponsor, Cooper Medical Center of Rowan University, and our host this morning, the New Jersey Psychological Association. We appreciate your attention to this topic, to the importance of understanding the role of anxiety and depression and substance use in our workplace, and we hope this conversation has sort of helped get your mind around a little bit in preparation for the soon may come day when we're all back together in person. And with that, I want to wish everybody a wonderful day and an absolutely terrific weekend. So be safe, wash your hands, wear a mask, keep your distance. Be well, everybody. Have an afternoon.